Welcome to the second in the series of two on the lecture considering gas exchange and transport. And we begin this lecture talking about reflex control of ventilation, and we'll continue with this idea of regulation of ventilation throughout this lecture series. So this is a bit of a busy slide, but we're going to take our time to go through it, first on the left and then on the right. We can see the circuitry in the brainstem. The pons is this green-colored region, and then the medulla is the more caudally located region, as you know, and it interfaces with the spinal cord. So by this time we have studied enough of the neurophysiology and neuroanatomy associated with that to know these regions of the brain. And we can see that there are various groups in the medulla of neurons, as well as there are areas in the pons that are interconnected with each other, either reciprocally or possibly just in one direction. And then these areas in the medulla will have fibers that very interesting how they show it. They're showing them going directly to the skeletal muscles for inspiration and expiration here on the individual's left side in the illustration. Unfortunately, that is an error because they do not have direct motor projections to these. They project down to the spinal cord or to the motor neurons that innervate subsequently these muscles. So these are actually called premotor neurons. So the physiology approach to neuroanatomy sometimes lacks a couple parts of the circuits. It is really well established that these are what are called premotor neurons that project to the motor neurons of the spinal cord and then on out. You will recall that we talked about the spinal cord having central pattern generators in neurophysiology, and that upper motor neurons would project down into the spinal cord or the pons to impact those, and then they could generate a pattern response. But it's the alpha motor neuron that actually projects to these skeletal muscles. We recall that the phrenic nerve carries C345. C345 keeps the diaphragm alive. So my primary reason for going through this illustration here is to remind you that the physiologists have taken license with the neuroanatomy to let us know that we have two different groups in the medulla, a dorsal and a ventral group. The dorsal group going to the motor neurons that control the inspiratory muscles, the primaries, and then the accessories, the scalenes and the sternocleidomastoid shown here. And then the ventral respiratory group in the medulla, as we see, innervates the expiratory muscles, and typically those are not recruited to any great degree, the internal intercostals and the abdominal muscles, during resting, relaxed breathing. So that shows us our integrating centers, if you will, and then the sensory and the output, the motor end. We should have started, I guess, with the sensory part, but I wanted to start right here with the core of neuroanatomy and get to the correction of this illustration before we proceeded. And then the sensory structures are coming from the aortic arch and the region of the bifurcation of the common carotid arteries. It would be on both sides, and there's this is just showing one side. There's two of these, are left and right. There's the baroreceptor, the carotid sinus that stretches, and the aortic arch that stretches. So we talked about that with the regulation of the cardiovascular system, blood pressure. And here we're considering sensory cells either scattered in the wall of the aortic arch or a very distinctive little body right here in the crevice created by the bifurcation of the common carotid into the internal and the external carotid arteries. And that's called the carotid body. innervated by cranial nerve 9. And then cranial nerve 10, the vagus, innervates these aortic bodies. The aortic bodies, typically that term bodies is related to chemoreceptors, although their stretch receptor function is associated with the same anatomical region within the walls of the vessels nearby. And that sensory information, actually both the pressure and the chemosensory stimuli, converge in the dorsal medulla region, an area called the nucleus tractus solitarius, the NTS. So we'll begin to build on these as we proceed. So now let's go to the image on the right and work our way through that. Let's start with the carbon dioxide and the oxygen and the pH and integrate those in just to the sensory receptors. And then we'll obviously go on to discuss the ups and downs of any one of these, or a couple of them combined. So there are the carotid and the aortic chemoreceptors that we talked about over here, but also in the brain, in the medulla, there are medullary chemoreceptors that are sensing the levels of these gases and the pH. Remember, we said pH and CO2 are always playing the same game up and down, except if CO2 goes up, pH goes down, acidity goes up, right? That old game of pH going down to make things more acidic. And the way to think about these is that the brain always takes care of itself. The CNS will take care of itself. So if it's using its medullary chemoreceptors to see what's going on as far as the blood coming to it, and then it has a comparator function somewhere within the integrating centers in the medulla oblongata, where the central chemoreceptors, the medullary chemoreceptors, and the peripheral chemoreceptors, the carotid and aortic chemoreceptors, through their cranial nerve 9 and 10 innervation of the medulla, will converge. So they come in and they do have points of convergence, and the CNS thereby can compare what it's receiving versus what's coming its way through the aorta and through the carotid artery system. So try to understand this in that sense, as well as just overall coordination of the regular breathing pattern. And we'll consider that first and take it all the way out, and then come back to this very obvious thing that we all pretty much know about, because we all breathe every day, so we know that we have voluntary and involuntary emotional control over the respiratory pattern, the ventilatory pattern. So the medulla oblongata, as we said, has output to the somatic motor neurons for inspiration and the somatic motor neurons for expiration. So here they're showing it, but they black box it all into these red lines here, which is just really horrible. I'm very disappointed with that. Anyway, we know that skeletal muscles are innervated by motor neurons, either of cranial nerves or of the ventral gray horn of the spinal cord. And that's just the way it is, so nothing changes that. So if anything is going to innervate one of those, then it is called a premotor neuron. In these cases, we called the premotor neuron of the somatic motor system in the primary motor cortex an upper motor neuron, but it's still premotor because it innervates the alpha motor neuron directly, and that's what these are in the medulla. They will innervate the alpha motor neurons and C3, 4, 5 spinal segments to keep the diaphragm alive, right? And so the motor neurons in the cervical spinal segments C3, 4, 5 are no good without this descending input. So if you get a transection of the spinal cord above C3, at, say C2, then the motor neurons that innervate the diaphragm through the phrenic nerve are still alive, but they do not cycle. They cannot be activated by any mechanism from above. So the motor neurons innervating the diaphragm and any of the other inspiratory muscles, the external intercostals that are still primary, and the scalene and sternocleidomastoid muscles that are secondary, Without that upper motor neuron innervation, you just don't get them functioning. So anybody that has a spinal cord lesion that involves the cervical region, if C3, 4, 5 are even damaged, much less if the lesion is above C3, then typically they're on an external ventilator. And then, of course, the same, we have the premotor neurons in the medulla that innervate the somatic motor neurons for expiration for the internal intercostals and the abdominal muscles. But remember, most of resting expiration is passive recoil, so there's very little activation of these neurons during resting ventilatory cycles. There's some, but not the same as when you're breathing really hard, obviously. Oh, we forgot to bring this in. So when you're startled, your emotion and voluntary control levels, of course, are residing in the higher brain centers, and they can activate the limbic system that can, through descending input, have impacts here. And one thing that we know, because we breathe, and we've been in situations where we feel like we're suffocating, right? We know that there's information that comes up to the higher brain centers from the medulla and signal to us that, we're not getting a sufficient gas exchange. And, of course, these are very important when we think about some of the psychiatric diagnoses, such as anxiety disorders and panic disorders. There's that sensation that I can't breathe, I'm not, I'm suffocating. So this circuitry can be altered, and we all know about it. If somebody puts their hand over our mouth and we feel that we can't breathe, then there's something coming up other than just the hand over our mouth and nose that lets us realize that we need to change our behavior to improve our ventilation and get the gas balances the way they should be to meet the metabolic needs of the body. So we know that the higher centers become recruited depending upon what's going on. But under normal resting conditions, when you're sitting and reading your textbook and studying, all of this can be maintained just at the level of the pons and the medulla without any need for sensory information to get up to the cortex to where you're aware of it. Now, when you're doing things like when I'm lecturing like this, my cerebral cortex is much more aware of the airflow and breathing and controlling the inspiratory and expiratory processes, as you know, and we'll see there's some protective reflexes, and you certainly know that coughing and sneezing and clearing your throat all fall into those categories, very coordinated actions of these neurons for controlling inspiration, expiration, but also of the muscles of the pharynx and the larynx and stuff like that to cough or sneeze and clear your throat. So we're not denying the higher brain centers influencing the pontine respiratory group, the PRGs, the pontine respiratory group, and then in the medulla there are two that we mention here, the dorsal respiratory group and the ventral respiratory group, and then at the rostral end of the dorsal respiratory group is the nucleus tractus solitarius, which receives, it actually has the second order sensory neurons from cranial nerves 9 and 10, cranial nerve 9 coming specifically from the carotid body, and of course the carotid sinus, and cranial nerve 10, oh wait, this is 9 and that's 10, sorry, cranial nerve 9 the glossopharyngeal, and the cranial nerve 10, the vagus, coming from the aorta. This sensory information comes in here, and then it is integrated locally. So this is what I said. There's convergence of information of both baroreceptor and chemoreceptor function, the peripheral ones, and then what they're not showing in here is they're just illustratively including it, the central chemoreceptors, the medullary chemoreceptors converge here as well. So that's what I said. There's the peripheral and central chemoreceptors converging in the NTS region, and you get a comparator function. What is the signal we're receiving as far as PCO2 and PO2 and hydrogen ion concentration in the medulla itself versus out there in the aorta. So is there a problem in between? Is this something we can regulate and improve the central condition or the peripheral condition such that we have a balance? But under normal conditions for breathing, the authors, of course, take you through this series of events very nicely. But the way that I want to do it is a bit more cursory. What I want to start with is the pre-Botzinger complex here. This has spontaneously firing neurons, and you see that there is a reciprocal innervation between this complex and the dorsal respiratory group. And remember, the dorsal respiratory group is going to have the output primarily to the inspiratory muscles, and the ventral respiratory group to the expiratory, and some inspiratory pharynx, larynx, and tongue muscles. So it is going to be coordinating many of the events. Think of sneezing, where you have to take in a deep breath and then you breathe out, and you're doing a lot with the pharynx, larynx, and the tongue muscles to execute a sneeze. It's a very complex behavioral response if you think about it. And so it has to be timed and coordinated. This, you can think of it almost as like the sinoatrial node on the heart. If something impinges upon it to speed it up, you have a faster ventilatory rate. Something impinges upon these autorhythmic cycling cells that have firing bursts. Remember your neurophysiology. It's the frequency and the interpulse interval. That's all you can change about a neuron. And these fire spontaneously. So how many acts and potentials in a burst, and what is the frequency of that, and then how long before another one comes. So think of breathing patterns. They're almost the same way. You're panting. So all of this would be doing it and controlling that cycling back and forth between those two. So it can be, quite rapid when you think of a dog panting, or someone that's breathing really fast and really hard, or someone who's struggling with breathing when they have asthma or COPD or something like that. So this neurocircuitry is very adaptive in that sense. So now let's look at some of the other circuitry. We've got the sensory coming in. So the NTS, or the second order sensory neurons. The sensory information is shared with the dorsal group directly, and then through ascending connections with the pontine respiratory group, that then has descending connections to both the dorsal regulatory group and the ventral respiratory group. Excuse me. And of course, the higher brain centers will impinge upon the pontine respiratory group. So this is where you get the coordination of all of the events for the patterning. So we'll see that there's going to be a recruitment of neurons that builds to complete inspiration, and then basically a release of those neurons. So this is a complex circuit to produce the rhythmical pattern of ventilation. We don't understand it completely, and our understanding improves all the time. Obviously, clinically, this is an extremely important function that we need to understand. So we continue a bit with this idea of regulation of ventilation. The respiratory neurons in the medulla control inspiration and expiration. The neurons in the pons modulate that ventilation. Rhythmic pattern of breathing arises from that pre-Botzinger complex that has the spontaneously discharging neurons. The ventilation is subject to modulation by the chemoreceptor-linked reflexes and by higher brain centers. So tremendous amount of integration going on here, but think of all the factors that can impact the rate at which we breathe. And remember, it's not only the velocity, there's acceleration of breathing patterns, and then there's the depth of breathing. So there's these characteristic features of a dynamic system that are all modulated above and below the certain baseline that generates the tidal volume, our basal ventilatory rate. So if we were recording from the phrenic nerve, let's say, as I state in the textbook, we could pick up the neuronal activity, the complex action potentials that build in the phrenic nerve just to contract the diaphragm through one inspiratory event. Remember, the inspiratory and expiratory is the cycle, and we've got about a 2-second inspiration and about a 3-second passive expiration with tidal volume. And you see the tidal volume here, of course, is roughly a half a liter. Here they're showing it's a little bit above that, but that's fine. And so in the inspiratory, the rapid rising phase, to increase the volume of the lungs, you're of course going to have this gradual increase in the firing of the alpha motor neurons in C345. So that's 3 spinal segments. So that's a lot of motor neurons potentially to be recruited, and it's very complex because you have to shift between motor units so that you don't fatigue the first one that you recruited and stuff like that. So this is a very complex process of contracting a muscle and not fatiguing the muscle, and also not fatiguing the neurons that are being recruited, because you're going to need them again within just a matter of seconds and every second of the day. So there's a lot of cycling among the pools of neurons innervating different portions of the diaphragm. But once you start a contraction, you've got to keep that part contracting, alternating between motor units that you first recruit and then recruiting more and more and more and more. And you've got to keep these initial motor unit pools active. So there is they call it a rapid positive feedback loop. But another way to think about it is just the cumulative recruitment of motor units over time. And yes, once you start firing some of them, then there are mechanisms where they recruit their buddies, and they recruit their buddies, and they recruit their buddies. So it is a rapid positive feedback loop until some point to where there's a trigger to inhibit all of them and just either put the brakes on or remove the gas pedal completely. And I'm not sure if they really have determined how much of either of those two, whether it's all just inhibition, putting your foot on the brake, or whether it is all just removal of the gas pedal, taking your foot off the gas pedal, inhibiting the shutting off the excitatory drive. It's probably a balance between the two. But you can see that it is precipitous. Boom, it stops, and then we exhale, right? So this is right at peak inspiratory tidal volume that this is occurring. So this is the natural rhythm within this circuit. And of course, we know we can change it because you can push from here to a higher level to take a deeper breath and extend the time of inspiration, or you can increase the slope of this if you anticipate that you're going to do it, and you in the same time period take in a larger volume at a faster rate. So keep in mind there's all of these things that we can change. So the regulation of ventilation, and one of the reasons that this is studied, of course, is that there's hopes that rather than simply being on an external mechanical ventilator, that we could naturally recruit the respiratory muscles. They're still there, the nerves still innervate them, or there's some way of stimulating them, and then a person could be free of their external ventilator. The regulation of ventilation continuing then, the peripheral chemoreceptors are located in the carotid and aortic arteries, as we said, and they're specialized glomus cells, so sometimes they're collected into little bodies. The carotid body is a distinctive one that is present in nearly every single instance that some anatomical studies performed to go and find it. The sense changes in PO2, pH, and PCO2, the central chemoreceptors, and there's changes in the carbon dioxide that will stimulate these as well. So we've got the PCO2, the partial pressure can be varied, and then of course the concentration of dissolved carbon dioxide related to that. So the regulation of ventilation now with this illustration showing the low PO2 on one of these glomus cells, and the authors note that this system only is activated when the PO2 falls below 60 millimeters of mercury. So that's really a very low PO2. So this means of triggering the activation of the carotid body glomus cells is only under severe conditions. However, we'll transition to talk about chemoreceptors otherwise. PCO2 increasing and pH decreasing, becoming more acidic. Those two are inversely related. When CO2 goes up, PCO2 goes up, pH goes down, remember? Because hydrogen ion concentration follows the concentration of the carbon dioxide. Those also are stimuli to bring about this same type of a response in these cells. So they somehow have sensing mechanisms for the dangerously low PO2 and slight changes in the PCO2 and the pH that converge on this same mechanism. They will close potassium channels. So under normal conditions, the potassium channels are open. So what's going to be the direction of the flux of the potassium? That's right, outward. So there's going to be an outward flux of potassium. When you stop that, you're no longer keeping the cell at a hyperpolarized state, and it will drift toward the more positive membrane polarity, in other words, depolarize, to a voltage, a membrane voltage, that will open the voltage-gated calcium channels. And so now we're seeing that even though we don't typically think of other cells as being excitatory, having excitable membranes, they still can have a membrane potential that can drift. Maybe they're not producing an action potential, but they have a membrane potential that drifts, and you get this regulation of proteins in the membranes, the voltage-gated ion channel, calcium, the most common one, associated with, of course, the exocytotic event to release a transmitter. They're calling it a neurotransmitter because the receptor is on a neuron, and of course that generates an action potential, as we talked about generating the what's the generator potential, remember, of producing the action potential in the peripheral process of a sensory neuron. And this signal goes to the medulla, as we had stated. So in low PO2, you're going to increase the sensory information. In high PCO2, or just the subtle changes in PCO2, are going to be changing the basal activity of these cells on an ongoing basis. So the sensory information coming in is giving baseline information about the PCO2. Hold your breath for just a few seconds, and PCO2 is going to increase some, and then this sensory information is going to increase. So nobody knows for sure whether it's different firing patterns, whether to communicate the PCO2 and pH changes versus the PO2, or maybe it is in the literature. I haven't read the detailed literature on this. But somehow there's a different signal send as to the slight changes in the CO2 and pH versus an extreme case. Right. So I'm not really sure why the authors chose to show this one that under normal conditions isn't functioning. I guess it's because they talked about the pathology, where we'll just mention it here. The chemoreceptors, both peripheral and central, for sensing the PCO2 and the pH changes will accommodate. And so in cases like COPD, where the PCO2 stays high all the time because you just can't blow it off, your lungs are not efficient. So, and of course the PO2 drops low too. So then what's happening is the PO2 is the only signal that the medulla is receiving to this circuitry as to what's going on with blood gases, period, because the central and the peripheral chemoreceptors have adapted and accommodated to the persistently high PCO2 and slight acidity. So they're no longer sensing any subtle drifts in the PCO2 and the pH. So then you put a person like this on PO2, you raise PO2, and what happens? This says, oh, we've got all the PO2 we need, stop breathing. So very interesting clinical application of some of the new information we have on how putting a COPD patient on too much oxygen too quickly can actually shut down their respiratory system. And that, as we said, is because this system that senses the PCO2, which we know is very closely associated with hydrogen ion concentration, so as the dissolved carbon dioxide and PCO2, and we think of them in parallel. As they increase, then hydrogen ion increases through this reaction with the carbonic anhydrase and the carbonic acid to generate the hydrogen ion and the bicarbonate. And from this reaction, it's the hydrogen ion that is the most important for pH changes, as well as for, of course, the sensory component in the central chemoreceptors. They can sense the hydrogen ion concentration, or they are sensitive to pH of the cerebrospinal fluid and to the dissolved carbon dioxide levels together. So this is what in the central and the peripheral chemoreceptor that we just looked at will accommodate if you have a chronic elevated PCO, carbon dioxide content and the hydrogen ion concentration that goes along with it. Remember again, as hydrogen ion concentration increases, we talk about pH decreasing, being more acidic. So keep that reciprocal relationship in mind every time I talk about increased hydrogen ion concentration. It's becoming more acidic, pH dropping. So if this accommodates, then this signal has no meaning in the circuit anymore. So the only information coming in with somebody with COPD is the level of PO2. Bring that into normal and it says, oh, you don't need to breathe anymore. Boom. Not good. Okay. Not even into normal, just bring it above the critical PO2 of 60 millimeters of mercury. So now let's follow this through. So as PCO2 in the plasma increases, the dissolved carbon dioxide freely crosses into the cerebrospinal fluid, but the hydrogen ions in the plasma cannot, or it's very, very slow because of the blood-brain barrier that we studied with the neurophysiology. And we know this reaction is ongoing all the time. Wherever there's carbon dioxide and carbonic anhydrase, you've got this occurring at a very high rate. It occurs spontaneously just in a can of soda that you have, but obviously the CO2 stays mostly as the gas under the pressure. But here it dissolves through these range of reactions. Carbonic anhydrase favors the direction when carbon dioxide increases to the right, and other times, if anything here increases, or if carbon dioxide goes down, then the carbonic anhydrase will favor the leftward reaction. So this is ongoing all the time. This is a very important enzyme with a freely reversible reaction for the survival of organisms, for blood gases and pH regulation, as we know. So the chemoreceptor response to changes in the plasma carbon dioxide are what we can consider in this slide. So let's think of a perturbation of the system. We increase the plasma CO2, and that'll increase the PCO2, and the plasma will lead to an increase in PCO2 in the CSF, as we saw, an increase in the dissolved carbon dioxide in the CSF. The carbonic anhydrase will increase the hydrogen ion concentration. Both the increased CO2 presence and increased hydrogen ion stimulates the central chemoreceptor, increasing the firing rate and contribution to the ventilatory circuit, the DRG and the VRG in the medulla, as we said. and will increase ventilation. At the same time, you have the peripheral arterial PCO2 stimulating the peripheral chemoreceptors, again with the increased carbon dioxide and the increased hydrogen ion concentration, both having a similar effect as we saw centrally. So this is that comparator system, the cranial nerve 9 and 10 bringing information into the medulla, along with the local central chemoreceptors, integrating the two of them, comparing and determining how to modulate ventilation to take care of this. Is it just a central problem, or is it just a peripheral problem? If it's it's really going to be just a peripheral problem. But if it's a central problem, then of course it's disjointed, and somehow you've got to increase the perfusion to the brain. If you have a buildup of carbon dioxide there, but not in the arterial supply coming to it, so then the brain is going to trigger a change in the autonomic nervous system to increase blood flow to itself to correct this, to remove this carbon dioxide. Hopefully that makes sense to you. So this comparator function of what's happening centrally versus peripherally is very important for blood flow regulation as well as ventilation, because if you can adjust it by blood flow, you may not have to change ventilation. But if both of these are coming in strong, where there's a peripheral CO2 buildup and hydrogen ion, and the central, then you know you've got to increase ventilatory drive to blow off the carbon dioxide. And of course, if there's a drop in the plasma oxygen, as we said, the PO2, below 60 millimeters of mercury is necessary for this. And then, of course, with the change in the ventilation, the modulation of the basal ventilatory pattern, you get the PO2 to raise, and that will inhibit this sensory input that is driving ventilation. And that's the problem with the COPD. This system accommodates and acts just fine with a high CO2, and only this one is giving the signal. So if you add O2 out here, it shuts this down, and you shut off the drive for ventilation. So in pathology of that type, for lung disease, it's very important to understand how these systems behave under normal conditions and under pathological conditions. There is an animation for this, of course. And then we wind it up by mentioning just a few of the protective reflexes. So there's reflexes for protection from environmental irritants. So the bronchoconstriction to keep things from getting too deep into the lungs, sneezing and coughing. So these are built in, and we know they're exaggerated if you have allergies. So there are some type of sensing structures in the air passageways that determine the particulate or suspended content of the air that is coming in, and have very potent reflex impacts on the parasympathetic nervous system that will trigger the bronchoconstriction, and the central pattern generator systems, including the circuits that we've talked about, the respiratory groups of neurons, to trigger sneezing and coughing. So the Herring-Brewer inflation reflex is also a very important one, and it classically was described as one where you prevent overinflation of the lungs. The authors in this current edition state that it can be observed in newborn infant humans and in dogs and other species, but it rarely is demonstrated in adult humans. So in other words, some of these in humans may be reflexes that are important developmentally, and they become overridden by the regulation of the system otherwise as we grow into adulthood. So the summary of this chapter, we covered many different topics, and we are reminded here's our friend carbonic anhydrase again with the chloride shift for handling the carbon dioxide at the level of the red blood cell. Very important there for CO2 transport. And then with the chemoreceptor function, both the peripheral and the central. So remember that the chemoreceptors can adapt to become accommodated to the persistent PCO2 and pH changes, but the PO2 sensor does not.